I would like to thank everyone for coming here today at Martin University. It was very important for us to choose Martin University because of just the legacy and the 50-plus years of history. So I'm going to pass it over to Dr. Sean Huddleston.
He said it was going to be short. That was really short, right? Well, good evening again. My name is Dr. Sean Huddleston. I have the privilege and honor of serving as the president of Martin University. Some of you have been here before, and some of you are here for the first time, but we have a little bit of a tradition that we've started here. So it's kind of a call and response. I say, welcome home, and you say, it's good to be home. Welcome home. It's good to be home. That's what I'm talking about. So as Robert indicated, Martin University was founded in 1977 as Indiana's only predominantly black institution of higher education. However, we do not think of ourselves only as a university. We actually think of ourselves as a communiversity. So we are in, of, and for the community, but most importantly, we are, one, a purveyor of collective impact, and we are where constructive activism occurs. So we help to construct solutions for our communities that can be activated. So there is no better place to have a conversation like the one we're going to have today other than Martin University. So we thank you all for coming, and with that, I am going to pass the mic over to Crystal Ratcliffe, president of the Indianapolis NAACP.
Greetings, everyone, and thank you for being here. Once again, my name is Crystal Ratcliffe, and I am the president of your Greater Indianapolis NAACP. What a wonderful place to be on a rainy, sunny day at Martin University. Racism is a public health crisis, and that's why we're gathered here today. So we're not going to keep you. These two gentlemen have given you plenty of the opening remarks of who we are, and at this time I'm going to hand it over to our moderator, Dr. Kelly McCants.
Thank you, thank you. All right, yeah, y'all can sit down now. I got it from here. So, first of all, thank you all for being here. This is such an important venue, an important university, predominantly black institution. I know a little bit something about that. I went to Meharry Medical College and Tennessee State University, the real TSU. And so I say that because I'm a product of an historic black college and university. I'm a cardiologist, specialized in heart transplant, and I represent 5% of practicing providers that are African American, and I come from an HBCU. So I'll try to stay on schedule today, but I just have a few opening comments. First of all, thank you to the NAACP and Indianapolis Recorder for being a trusted, we'll call them a university, being a trusted university to have conversations like the one we're going to have in a responsible way. If you're here in this room, you recognize that racism is a public health crisis, or you wouldn't be here. But you also have a passion to work together to fix it. So let me just set the stage by saying who I am and why I think I'm a little bit qualified to speak about this. So I run the Institute for Health Equity at Norton Healthcare in Louisville, Kentucky, not too far from Indianapolis. If you're driving south, you'll run right through us. But the most important point is the CEOs and the chief human resource officers have the responsibility and ability to set the stage for how an organization moves, keeping healthcare disparities at the center. And so you have the most important people in the room, and we'll ask them some questions in a responsible way and really just try to get a feel for how they think their organizations should not only respect black providers, but deal with racism as a public health crisis. So let me go back to setting the stage. So our CEO, Russ Cox, phenomenal CEO, he had the challenge of setting the stage for how our organization would move in Louisville, Kentucky. If you know anything about Louisville, it's an awesome place, but healthcare disparities are real. 86% of all African Americans in Louisville live on one side of town, which means if you want to guess where the healthcare disparities are, you can. And so our CEO said, hey, we're going to approach this in an intentional and thoughtful way. And so he had the entire organization set to move about 5 imperatives. He said these are not initiatives, these are imperatives. And the first imperative was to establish the Institute for Health Equity, which is led by me. I was blessed to take the lead about 3 years ago. And the Institute for Health Equity is a site-based investment in that part of Louisville where 86% of African Americans live. In that institution, we have uncomfortable conversations, and we collaborate with community-based organizations and try to figure out how to attack systemic racism. The second imperative in my mind was probably the most important, which is to make sure that each individual in Louisville has access to primary care. It doesn't matter which organization is providing the health care, we're taking care of a collaborative community. And so when I see these organizations here working together, it means that they truly understand why we're here. The third imperative is a little bit direct, I would say, and that is to mirror our community. And so the chief human resource officers are here. They'll talk about workforce development and why pipelines are important, i.e. Martin University, Tennessee State, Morehouse, while pipelines are important, because we ought mirror our community from our boardroom all the way down to our cafeteria. The fourth imperative that our CEO set us on was to engage. Means engage our policyholders, our mayor, our councilmen, our representatives around policies that have healthcare disparities at the center, which is extremely important. So once a month, we have a platform where all 18,000 employees have ability to interact with our local politicians to say, if you're going to put policies in place, make sure that healthcare disparities are at the center. And then finally, the most important imperative was number 5, which is an economic investment into the West End in Louisville. Now, we started out with the goal of $20 million over a 2 to 3 year period. We're above $100 million now. And the hallmark of that, please clap. So the hallmark of that $100 million investment is another site-based investment with putting the first hospital in the African-American community in Louisville in over 150 years. And so when I say that we know a little bit about healthcare disparities, we don't have all the answers, but we certainly got off to a good start. And I'm hoping that our conversations here also put the city of Indianapolis along the same direction. All right? Thank you. We'll get started. Sit in my chair. So I have the pleasure of introducing, and I'm gonna read this, the first CEO, which is Brian Mills. Brian, raise your hand. All right. So if you have watched any of the videos leading up to this event, and Brian, I just wanted to say, on video, your passion for what you're doing is clear. So I know we'll hear some great remarks from Brian, but he serves as the CEO of Community Health Network for almost 40 years. So anybody that's been doing something for 40 years has done a good job, or at least has made all the mistakes and knows how to do right now. But Brian is probably one of the most respected CEOs in the city, and he leads Community Health Network Hospital. He began his career in 1985 as a controller, so he knows a little bit about everything. I think what's most important is that he's active in his community, and the fact that he's here, his community is not just a majority community, it's an entire community. Brian, in 2022, was recognized by the Business Journal as one of the most influential business leaders in Indiana. So please give Brian a warm welcome. Thank you. And next up is Lisa Harris. So Lisa also has over 40 years of experience in leading. And again, anybody that's been leading for 40 years knows a little bit about how to lead. But she's the CEO of the Eskenazi Healthcare System and has dedicated her entire career to improving healthcare for vulnerable populations. Dr. Harris is intensely focused on promoting health in all of its dimension and, of course, improving access. She's a current board member of the American Red Cross, again, working in the community-based organizations, as well as she's on the board of directors at Martin University. All right, let's welcome Dr. Lisa Harris. The next up is Lori Price, President and CEO of Franciscan, the beautiful hospital that I see when I ride down 65. So she's been CEO of the Franciscan Healthcare Center and all of its affiliates. I think the most important thing is, again, the longevity that she's had in healthcare. She serves a system that deals with 1.6 million patient visits. And so when you talk about leading an organization that touches so many lives, the CEO, again, is at the forefront. Before joining Franciscan's Health Ministry, Lori was Chief Operating Officer for Metro Health University in Michigan. Her career has included a depth of experience in clinical care as a nurse in a variety of executive leadership roles. So for a nurse to rise to the ranks of CEO, she must be impactful. And some of the disciplines are listed here: cardiology, orthopedics. Congratulations, and welcome the CEO of Franciscan. All right. Next up is Dennis Murphy. And Dennis is the CEO of IU Health. I think the most important thing about IU Health, it is one of the largest healthcare providers in Indiana with over 38,000 employees. Now, I mentioned earlier at Norton Healthcare we had 17,000, but running an organization that has 38,000 employees in an integrated fashion is phenomenal. I think what's most impressive looking at Dennis's bio is that he has a long-standing commitment to academics. So he's previous leadership positions in Northwestern Medicine, University of Chicago, and of course, Johns Hopkins. A native of Chicago, Murphy earned his Bachelor of Arts degree from the University of Notre Dame and a Master of Healthcare Administration at Duke. So when you talk about academics, he is the man. Welcome, Dennis. Okay. So we have a panel of questions, and Gary's going to keep me honest on time here. The first question is, what methods are you using to advance your understanding for what's happening to African American patients in your hospital? Brian, would you like to take that one?
Sure. Well, first of all, I do think it's important that everybody knows we're here as peers, we're here as friends, we're here to work together. And I think that's something that the audience needs to know, because we've had these forums in the past, but we haven't had a live audience. And this is wonderful to sit here and talk directly to you. So we are working together, and I think that's important, and I think that we'll be held accountable together. As we talk about our patients, I mean, we have very good data on patient experience. We have patient advocates. We've added people to our organization for health equity to make sure that people can have a conversation with people who look like them. We've had all kinds of education and training with our workforce, with our providers throughout. But most importantly, we come together to look at our results and see how can we improve what we've done. Have we solved this? No. Are we committed to get better every day? Yes. But we have to do that by sharing. And I think one of the things that we have here in our own systems is data, but when we're sharing that with our peers, we can all get better.
So one of the things that I commented earlier on was that you have, again, 4 CEOs here working in a collaborative fashion. And Brian reminded me that that wasn't unique, that they've been working together for years. And so when you think about healthcare disparities and how it takes a cohesive medical community, sounds like these 4 organizations are off to a good start.
Build trust. We have to invite people into our organization. They need to feel welcome, regardless of color, regardless of any other diversity, attribute. Yeah, thank you.
Go ahead.
But we have to have that, and that's got to change. And so if you were to walk into our facilities, I would hope you would feel welcome. And I think the more we do that and the more we stay on top of that, the better we are in achieving our goal.
Lisa, would you like to comment on the same questions? Same question, what methods are you using to advance the understanding of what's happening to African-American patients in your hospital?
Yeah, sure. I would endorse everything Brian has said, and then add to that we rely on data, the histories and physicals and test results and patients' reports of their care. I think we have to remember that not all the issues related to racism can be measured. And so as we're doing this, we have to remember that there are individuals that because of past experiences with racism, they didn't feel welcome, they didn't feel comfortable seeking care. They don't, so they're not coming to us for care. So they're not in, we don't have any information about them. So these dashboards that we're compiling, where we're looking at data across all of our systems, focused on the morbidities that most affect our community, their information isn't in there. I think also we have to be concerned sometimes that the measures we're using can be biased, and that's where the concern about artificial intelligence comes in, and recognizing that the algorithms are they're not populated with data about healthcare that represents the full array of individuals in our population. So there's a concern there. And then I think the other thing is that we have to be mindful of the fact that even though folks' outcomes of care may be comparable, so we're looking at data across various, all the processes and outcomes of care by race, the outcomes may be the same, but that doesn't mean that someone didn't experience racism in the process of their care. So that's why it's so important that the most important thing we can do is talk to patients and talk to their families and do the surveys when we see complaints of racism, that we take those complaints seriously and we investigate thoroughly. So I think it's a matter of remembering what's not in the data that we're working so hard to compile and use to focus our efforts.
So as healthcare providers, we rely heavily on the data. And so to hear both of these CEOs understand and admit that the data is limited, some of the information we get from our community needs assessment and our health equity reports is dated, and everybody's not responding to the questions. And so very encouraging to hear you both say that the data is often limited. Dennis or Lori, any comment on this question before I move on to the next one?
I think I would just add that, I've been in my role about 3 months, so coming in kind of new to the Indianapolis area, but this group has already been mentioned. Coming together is probably the most significant aspect of that work, and I can take no credit because these 3 and Dr. Callan before me did that, but in many other communities I've been, this type of collaboration does not exist, and so putting some of the competition things aside and really concentrating on what matters is, for me, very refreshing and exciting about coming into this new role. And she's right, we collect lots of data, we all look at our own data, but I think for me, coming into this new role, it's that whole conversation around unconscious bias. We don't know what we don't know sometimes, how we've been raised and, where we went to school, and you get these perspectives, and we just gotta remember that coming into that, and that's what's great about this, is having all of us together looking and working together.
We have time for Dennis to comment. Please, Dennis.
Maybe I'll go. I completely agree with the other 3. There's sort of data, then there's sort of this human interaction that's essential. But maybe a couple of specific programs. We've started at Riley Children's Hospital, where we do our deliveries, actually a doula program for BIPOC patients. So people of color, Black, Indigenous patients, following them from 28 weeks of gestation through a year afterwards, because there are very differential outcomes for Black mothers and Black babies. And so we're really starting to see some uptake in that program. The other that I think is really interesting, like Brian, we have patient advocates, but we use a tool that was put out by the CDC that measures social vulnerability, and really tell the advocates, start with those people first. They're the ones in most need, and they're the ones who probably don't proactively raise their hand and say, I need help. So I think those two programs, and then a program that we see pretty prevalently in pediatrics is trauma-informed care. And actually, as somebody who's done this, not as long as some of my peers, but over 30 years, I didn't know what that was. And actually, I think for a lot of people in adult medicine, understanding how to ask those questions of patients and probe to understand more than just their diagnosis, more than just their typical social history, but actually digging a little deeper, I think is really important.
So you're leading us into the second question, and you spoke specifically about disease states in young adults and infants. So the next question is, describe the level of collaboration on key morbidities affecting the African American community. And you were leading into the infant mortality rate and some things of that nature. And African Americans have the highest infant mortality rate in the United States. But also, the United States has the highest infant mortality rate out of every country in the world. And so I think when we're speaking about infant mortality rates, if we were to go to another country, they wouldn't say, hey, those African Americans have the highest rate. It's the United States. So go back to that question, and we'll start again with you, Brian, if that's okay. Talk about key collaboration around certain morbidities that affect African Americans more than others.
But I want to start a little bit upstream from that, and that is, it's the education of our staff. It's the education and the welcoming of people into our organization, that we can establish a relationship that people can share, and that we talk to people in their language, or we get people, as I said before, that look like the people we're serving. And that's so core. I mean, the data, the results on the other end are what they are, and that's what nobody likes. But I still believe fundamentally in all this is that we're people serving people. And in a healthcare organization, you know, the majority of people come in, we haven't seen them before. You know, and the trust that we have to establish. I mean, the fact of just sitting down, talking, looking somebody in the eye, get them a glass of water, whatever, those are just normal relationship building. And that's what our staffs have to become. You know, the clinicians can take over on how we go about doing what we do. But I think so many times we're not trusted. And so people don't come. And even if in fact they know something's wrong, they talk themselves into not doing it. And then at the same time, I think we have, wherever these people are employed, their employers got to be empathetic. I mean, this is about people. And I realize I didn't directly answer your question, but that's still where I go, because I think that's our best opportunity to change, which is the culture of our organization and the welcoming of anybody who walks in the door.
No, I wouldn't say you didn't answer. I think you did a great job answering that question, but that question can evolve to the discussion of trust. Because we can talk about hypertension, diabetes, renal insufficiency, whatever you want. Every disease, every chronic disease that you measure affects the African American community. But if you don't have the trust, and if you're not speaking to your providers about establishing the trust, then we'll never get there. And so I'll give Lori and Lisa an opportunity to answer also, but you said something that was extremely important. When you walk in the physician's office now, we're so busy typing on the computer, we're not making the eye contact that Brian just spoke about. Well, culturally, that says different things to different people. And people of color like that interaction, realizing that when you go home, you may have to spend 30 more minutes doing your charts, but what happens during that interaction continues to build trust. Would you like to comment?
I love that we're taking this direction because I think that the trust is about empathy. And that is what when we talk about wanting to build a diverse workforce, that recognizes that empathy is the ability to understand and share the feelings of someone else. And in healthcare, to act on that, to bring that empathy into our practice. And so that empathy comes naturally if we have shared life experiences, but that, for many of us, we have not. And so that's why it's so important that we create the diversity among our providers, all of the members of our healthcare team, so that patients and the caregivers are more likely to get to know each other. You know, we talk a lot about the importance of, for example, more Black physicians, and we are very committed to that. And we're doing a good job, I think, in working toward that. But we know, I'm sure you know the data, that if we doubled the number of individuals graduating, the Black individuals graduating from medical school, doubled year over year for the next 66 years, that's what it would take to actually make up the gap right now. Our population's becoming more diverse at a faster rate than that. So that's why it's important at all levels that we focus on what we're talking about this evening, which is about building that workforce that becomes comfortable, our patients become comfortable with us, and we can bring what I think is the most important part of caregiving, the empathy to the equation.
So as CEOs, you're often accused of only thinking about things that make money and the bottom line. But if you hear these CEOs answer the question, it's feel good. It's all about humility and having the right providers, having the right discussions, and that's encouraging. Lori, would you or Dennis like to comment?
Sure. Some specific programs that we're working through, we all do a community needs assessment. That's kind of a basic thing we all do and collect that data. But then we've been working with many of our community partners in different areas, and specifically diabetes prevention. And we're working with the state of Indiana and others and getting grants, but specifically for our Black population, our Burmese in southern Indy, and our Sikh population. So we're working on a program there specifically for diabetes, which is a big problem specifically for the Black community, but for the other communities too. In addition to that, we have a new specific grant that we're working through, and that's on suicide prevention. Another very challenging health issue to take care of, especially post-pandemic. A lot of people went through a lot of stress during that time and still are, and looking at those two. So those would be two recent examples, yeah.
And she's given a shout out to the November town hall, which will be on mental health and behavioral issues. Dennis, would you like to comment about trust and why that's important?
Yeah, I think, so you dubbed me the academic guy. Actually, I had two parents who graduated from 8th grade, and that was it. My dad was a plumber, and he always used to tell us, don't cry over spilled milk, do something about it. And so I think one of the challenges for us as a set of CEOs is doing something about it. So I think we're very fortunate. Each of our organizations has some great physician leaders in this space that have said, let's pick 4 things and start with those 4 to do something about this. So you mentioned behavioral health, you mentioned diabetes, hypertension, which leads to a whole series of issues, and infant mortality. And I think what's really powerful is that all 4 of us have said Those are our big four things. So trying to create some momentum around changing the outcomes in our community on those four things. And so maybe just one example, I think Cincinnati had a wonderful model called Cradle Cincinnati, which was really a partnership between healthcare providers and community organizations to take care of mothers and infants. We're trying to replicate that here in Indianapolis. We've also been very fortunate. They have a partnership with Novartis, which is a drug company who's actually doing specific work with us at IU Health on hypertension in Black communities. So I think what's been powerful about this partnership is to say, let's focus and let's use data to show that we're actually making a difference. Because I think at the end of the day, that's what our community wants. They need to trust us, but some of that trust comes with putting your shoulder down, do your work, and make a difference. And then they'll see that we're committed to this. We were actually talking earlier, Lori and I were both in Chicago, and they made a similar pledge to health equity right after Floyd's death. And I actually think when I talk to them, they don't have these discussions. It's gone. It's kind of evaporated. So I do think the trust also comes with material change and persistent commitment. And I think it's why I value the NAACP and the recorder. It's a good accountability function. That trust has to be earned and has to be delivered on. So I think we welcome these forums because it's a way of keeping our focus on this.
And one thing, so go ahead.
Specifics that draws in Martin University, and that's the partnership that we have in behavioral. You made reference to behavioral health and a community health network, and Eskenazi both have very large community mental health practices. So we are collaborating on a behavioral health academy to work to grow the mental health pipeline to keep up with the increasing need for services. And we want that workforce to mirror the community we serve, and so that's where Martin comes in as a critical element of that pipeline.
So both Dennis and Lisa spoke about intentionality. And so as we wrap up our last question, I want to talk about the intentionality behind mirroring your community from the C-suite level. And it's also a nice segue into the next part of this discussion, which will be the community health resource officers. But talk to us about the intentionality in the C-suite from a diversity standpoint. Brian, would you like to start?
Yeah, I would start just one elevation above that, which is our board of directors. So we felt that we had to resemble the patients we serve. And we looked at our board at 3 years ago, 3.5 years ago, and said, we had a great board. A lot of people have been there a long time. And we had a board set up that every person had a 1-year term. So at any time somebody could go in, and early on there was turnover. But over the last several years, we had not had much turnover. So we went through and revamped this and said we were going to make some changes. And so the diversity of our board has changed dramatically over the last few years. And with that, as we look at the people that report to me, I'm trying to make sure as well that we resemble the communities we serve. And so we've made significant progress there. We still have work to do. But I also believe it's got to be not only there, but throughout our organization, because I like to say, if I say it, it's going to happen. I know there's zero chance of that at work or home. But the thing about it is, it's us giving people a picture of what it's about, being held accountable, and throughout our organization, identifying, having the same expectation. Because a lot of people, I think they want to do this, they're scared, and as leaders. this has always worked for me, whether it's right or wrong. And so the education, being patient, okay, that's not a skill of mine, but an attribute. Being patient to go through this is something, and we have to find ways to coach up and get people engaged and make sure that we understand this is about the people we serve. It's not about us. And so that's kind of a summary of the changes we've made.
Excellent, excellent. I mentioned 5% of practicing providers are African American, but let's take professionals. So a lot of times when we're trying to establish folks in the C-suite, how do you make sure that you get to a point to where you understand that there is a deficit? You mentioned that we would have to double providers for the next 60 years. The same thing can be said of healthcare administrators. So talk a little bit more about the intentionality in finding those Black and brown providers in the C-suite.
Thank you. At Eskenazi Health, our senior leadership team is comprised of 29% of diverse individuals, 18% of whom are Black. And our Chief Financial Officer, Nicole Harper, reports directly to me, as does Krista Hicks, our Chief Human Resources Officer, who's here with us this evening. Curtis Wright, who is our Chief Executive Officer of our aligned physician group, Eskenazi Medical Group, reports to our Chief Medical Officer. So I think we have to have that representation. Nicole Harper put this really well when we started this very deliberate work, that we need to be able to look up and see people who look like us. Nicole was not our Chief Financial Officer then. The person who she replaced was Black. She who went on to Hopkins, good for her. we were very happy about Sharon Rogers' opportunities. But so we want to make sure that our leadership team is as inclusive as it possibly can be. So as we work deliberately to improve upon that inclusion, we've developed a leadership fellowship. And this is focused on identifying and developing the promising leaders within our organization, and then promoting from within. And one of the individuals in that program put the value of it really well when she said, when we see a critical mass of Black leaders in the room or around the table, we feel more comfortable speaking up. We feel more comfortable sharing our opinions, bringing our full selves to our work. And this woman is just one of many talented individuals in our system who has great insight, who has terrific ideas. And the fact that she's now more comfortable sharing them with us is to our great advantage.
We doing okay on time over there, Gary? Yeah. So you said something very, very important. And again, I keep bringing up the 5%. It can be doctors, it can be nurse practitioners, it can be bankers, it can be lawyers. Any high, I shouldn't say high, but Black professionals generally make up 5% of the area that they are in. And so you brought up having mentorship, because often African-American leaders are the only person in the room. And sometimes it makes them uncomfortable, even if they don't say it. And so having someone that looks like them that they can bounce ideas off of is extremely important. When I was blessed to be a leader at Norton Healthcare, I was the only African-American on the leadership team. And our CEO is awesome. And when he put the imperative, mirror our community, it has changed dramatically. But that's so important for psychological safety at work, to be able to have someone to have those discussions with. All right. Would you like to have, we have time. I'm regulating, we got time. What's wrong? Go ahead.
So our administrative team, we have about 12% made up of African American, Black population, Hispanics about 8%, and about 5% in Asian representation across our leadership team in Central Indiana. In my direct team, you'll be hearing from Steve Kyle, who's our HR leader in Central Indiana. In addition to Steve, our IT leader, and we have a sister who's a fellow right now in one of our programs, and she's also on our administrative team, and she's learning lots of healthcare. She comes from education, so she's coming from a different area to learn healthcare, to be that leader in healthcare. And just like Eskenazi, we too have an administrative fellow program. One of our fellows is here today. I see her. She happens though to be at our West Lafayette facility right now, and I believe she's started a Latino health administrator group locally. So she's been instrumental. But yeah, always more we can do and continue to do on that. I feel great about the organization and where we're headed, and the more we can do to emulate our community will be great. Yeah.
Dennis, please.
Well, maybe I'll take a very small sliver of this, but maybe the fundamental problem you talked about at the beginning, which is, do we have physicians that look like our patients? For many of you, you may not know that Indiana University has the largest medical school in the country. And actually 50% of all the physicians in the state train with us at some point. And I give a ton of credit to Dr. Tucker Edmonds, who is our Vice President for Health Equity, for thinking about a program we call iDream, which is really about how do we take our diverse medical students, because I think you have to start that far back. And it's really interesting because we actually do better than the national average when you look at our medical school class. We have a more diverse class, but over time when they go into their residency, we lose people. When they go into fellowships, we lose more people. And then when they finally decide where do they want to work, we lose even more people. So the idea is, how do you find people in medical school and keep them here? And maybe they go away for their residency, but we want them to come back. So I think we have to build programs that tell people, we want you here and we need you here, because I'm not sure they always got that message. And it does relate to this critical mass issue that, but I don't know how you build that unless you're conscious and you're creating real programs. So some of this is we're helping them pay off their loans. The other is we're giving them space. As you said, academics is important to us to build their academic skill set along with their clinical skill set. So I do think you have to be intentional, like you said, and in this space, like so many others, you've got to build something concrete if you're really trying to make a difference.
All right, awesome. Now it's my cue on time. But thank you all for being here. I've enjoyed speaking with you, and hopefully the audience realizes the dedication and passion that these four CEOs have. And again, leading their organizations to the right direction regarding healthcare disparities and health equity. They'll be hanging around a little bit later in the back of the room. We'll have time for audience questions. If I save time, I'll do my best to. But thank you all. It's been a pleasure speaking with you. Look forward to the next town hall.
Despite there being no biological differences by race, the medical community has historically, and in many cases, continues to use race to explain differences in health without acknowledging the role that racism plays in shaping these differences. A recent KFF survey found that Black and Hispanic adults are more likely than white adults to report being treated unfairly because of their race or ethnicity while getting health care for themselves or a family member. Black adults are also more likely than white adults to report certain negative experiences with healthcare providers. In addition, today, some tools that are being used to guide care and treatment decisions use race as a factor in ways that may contribute to health disparities. For example, there has been a lot of recent attention to the use of separate measures of kidney function for Black patients versus other patients, which may result in delayed access to care as well as transplants for Black patients. However, we see similar examples across other medical specialties, which together may contribute to both undertreatment and overtreatment of some groups, as well as delays in diagnosis and care. In 2020, the American Medical Association adopted new policies to recognize race as a social construct and to encourage medical education curriculum changes to explain how racism results in health disparities. The following year, the American Society of Nephrology and the National Kidney Foundation recommended that race should not be included in equations used to estimate kidney function. And since then, multiple hospitals and healthcare systems have removed the use of race as a factor in kidney function estimates and in some other clinical calculators. Going forward, it will be important to continue to assess how the medical community is reevaluating and revising how race is used to guide care and treatment.
So I'll start with introducing our first Chief Human Resource Officer, Michelle Mahaffey. Is that right? All right, I'm going to read this. So she's served as Executive Vice President and Chief Human Resource Officer for Community Health Network since 2020. She served several leadership positions in multiple industries over 25 years. There's that longevity again. Throughout her career, Michelle has been a champion of management, DEI, leading efforts in organizational redesign, mergers, acquisitions, spin-offs. I can keep going and going and going and going. She received her bachelor's from the University of Kansas and her MBA with concentrations in finance and HR and management from Vanderbilt. Strong hire. Welcome, Michelle. And next, is it Christia or Krista? Christia Hicks. She serves as the Chief Human Resource Officer at Eskenazi, a leading academic medical center, which we've heard about earlier, facilitating, again, more than 1 million outpatient visits. She matriculated at Augustana College with a degree in biology, so she must be smart. She has a master's in physical therapy, so well-rounded, Drexel University, and a master's of business administration from Indiana Wesleyan University. Welcome, Christia Hicks. All right, Stephen Cowell is Administrative Director of HR for Franciscan Health, Indiana Division. He's had over 25 years in human resource longevity. Again, he's got a bachelor's degree in social work. Again, well-rounded individual from Manchester University, master's degree in social work from the Ohio State University, and a master's degree in business administration, again, from Indiana Wesleyan University. Welcome, Stephen. Dr. Adriana Sims is Senior Vice President and Chief Human Resource Officer at Indiana University. Prior to joining IU, Dr. Sims was Vice President of Human Resources at Talent Management at One America. Prior to that, she served as Vice President of Talent Management at Dick's Sporting Goods. Held similar positions at Elevance Health, Roche Diagnostics, Novartis Pharmaceuticals, Bristol Myers. Listen, we got a star cast here. So somebody should be doing some recruiting. But welcome. Okay, so I purposely switched this question around, and I want to ask this question first. And it goes back to pipelines and the importance of predominantly black institutions and HBCUs. It says, how important are HBCUs, or historic black colleges and universities, in education of professionals and pointing them toward healthcare disciplines? And I said pointing them towards because, you know, when you go through college, you have a wide idea of what you want to do, but we need healthcare providers. And so how important is the pointing for HBCUs toward healthcare? Why don't you start, Michelle?
Thank you. It's extremely important, and I'm going to add a little bit even before the HBCUs. We had the honor of sponsoring Black Men in White Coats here in Indianapolis last year, which I hope most of you or all of you are familiar with this. It's an amazing opportunity for very young people, most of which are Black and African American, to experience the healthcare industry, experience wearing a white coat, experience learning how to do CPR, but we really do believe in pipeline. Starting young, making sure people are interested so that when they do go to college, they know what they want to pursue. I heard a story a week or so ago, a young Black man who had just been admitted to Howard University, and he was just so excited. And when he was asked why he was so excited, he said, "My whole life I've been one of the only Black kids in my classes." And it just made me think about how comfortable he was or was not in his learning experiences. And in this interview, he went on to say, "I am so excited to go learn alongside other people who look like me, and I can only imagine how much even better I'm going to be." So that really sunk in with me. And we do work with HBCUs. Tennessee State is actually one of our partners for nursing. We recruit heavily from Tennessee State. So, yeah, very important.
Thank you for that. And as you were highlighting that young man, I remember being in a heart transplant conference in San Diego, and I looked around, and I was speaking about heart transplant, and I did not see one other African-American physician in the room. So, yes, I was nervous, but boy, I sure was even more nervous after that, so that resonates with me. All right, Ms. Hicks, talk to me.
Well, good afternoon. Thank you for having me, and I'm very excited about this question. About 2 years ago, we did something very intentional for our students who are attending HBCUs. As a mom, I have 2 daughters that attended HBCUs, and when they wanted to come home in the summertime, they could not find meaningful internships. So as a leadership team, we discussed it and decided we wanted to do something meaningful for these students because a lot of HBCUs are in cities and states outside of this one. And so we started a paid internship program for students with HBCUs in 2021. We had 2 students. Then in 2022, we had 12 students. And this year, we have 16 students.
Wow.
Very excited about that. And so they have internships in their respective fields of studies, but then we also do professional development, everything from networking. We take them to lunch and learns. They have the opportunity to interact with different providers in the organization, show them what right looks like. You know, our leading trauma surgeon, Dr. Clark Simons, spent a lunch and learned with the students and talked to them about his journey and how he was the only person in the classroom and those things that he was able to use to persevere. And so we're very excited about this program, and one of our first interns actually works for the hospital now, and so developing that rich pipeline.
Talk about pipelines and intentionality. And so if you're not familiar with HBCUs, it's not that, you know, some people would say, well, you know, you got all Black students going to a school, isn't that the opposite of this? That's not what happens at an HBCU. At an HBCU, often young people that did not have a chance to enter college, they enter, and the professors wrap their arms around them and make sure they build character. And so often the product of an HBCU is well-rounded because they've had to struggle in order to get there. So it's not being exclusive, it's making sure that you continue to push someone toward academic excellence who may not have had family members or other people to go to college before them. Steve, talk to me about HBCU.
Sure, certainly. I think one of my experiences back when I was applying to graduate school, I had applied to Howard University and got accepted, and I also got accepted to The Ohio State University. And when I spoke to the admissions person, I told him I was going to The Ohio State University, and he said to me, "You will not have the experience at Ohio State that you'd have here at Howard." And you know, you think back to what that experience could have brought me versus Ohio State. I love Ohio State, but I think back, what kind of experience could I have had there, you know, with the HBC. But from Franciscan standpoint, what we try and do is we try and plant that seed early. We work a lot with kids that are getting ready to go off to college. And so we want to make sure they understand the opportunities that we have here at Franciscan for them, understanding career opportunities. So as they reach out and they go to that next step, they have a direction and they know where they can come back and resources and mentors through Franciscan.
Intentionality again. All right. You want to have a comment for us?
Certainly. So having not attended an HBCU, I do have two siblings who did. All of us ended up with our doctorates, MD and EDD and a PhD. And so we have great debates over the value and the benefit of an HBCU education versus not. But I think it's critically important. And at IU Health, we've certainly focused more on local and regional institutions and high school internships. So we have an IU Health Fellows program with Crispus Attucks. We've got a relationship with Providence Ray. We are increasing our focus on building pipelines in our high schools, but that doesn't preclude us from understanding the value of HBCUs. So, being that I'm just 6 months in the role, I've got my eye on Spelman, Tuskegee, you're smiling, Oakwood. They all have great healthcare management or nursing programs, and so we're going to explore some relationships with them. I think the reality is it's sometimes hard to recruit students from HBCUs, particularly those who came from larger cities. But I think if we work in partnership and in tandem, showcasing Indianapolis and the value proposition of being here in the community that does exist, I think we'll have a great opportunities to do some of the things that you guys have done in terms of doubling and tripling the number of interns and then hopefully turning those into permanent hires.
Wow, she could recruit anybody. So if you are a practicing provider in the United States and you're over the age of 50, let's say, there's an 80% chance you came from either Meharry Medical College or Howard University. In the early 1900s, the Flexner Report closed 80% of all medical schools. And when that happened, most African-American medical schools were closed. And so Howard and Meharry held the charge and graduated most of your practicing providers that are over the age of 50. Now I'm 47, so let's not. But I did go to Meharry, and our class size was about 110, and 70% African American. And so again, I make that point because it's not all about exclusive. It's about giving people opportunity. And so even though we were 70% African American, we had 30% non-African American at an HBCU. All right, next question. In your opinion, talk about the correlation or importance between having minorities working in healthcare and identifying with their patients. This is so important, and your CEOs all alluded to it earlier, but I'd like to give you guys an opportunity to comment.
Absolutely. And I'll start with the word that Brian used, which is trust. We know that health outcomes are better when patients feel comfortable, they feel safe, and they are treated by people who look like them. So we are very, very focused on increasing the diversity of everybody in all of our organizations. We have several hospitals, several ambulatory locations. We've got 16,500 employees. And we are doing everything we can to mirror the communities that we serve. So I think it's extremely important. Very rarely does someone come into one of our facilities and they want to be there. It's automatically an uncomfortable situation. So everything and anything we can do to make people feel safe, feel heard, is going to lead to better outcomes.
You know, you said something extremely important. We're in the medical profession, so when people come in, they're not feeling their best. Patients may come in and may not say the right things to staff, may be aggressive because they're hurt and they're seeking help. So it's important that the staff on the other end is educated and sensitive enough to deal with people. And often patients of color, and there's data for this, they come in with biases just as well. And so having a team like yourselves to educate your providers is extremely important. Would you like to comment?
I agree with Michelle. She stole the thunder when she talked about trust, and I'll echo a word that Lisa used, which is empathy. You know, putting yourself in a position to really understand, relate to, and share the feelings of another individual. That's why we work so hard to have a diverse workforce at Eskenazi Health. Research shows that patients have better outcomes and a greater sense of satisfaction when they're working with someone that looks like them. And so, but we have work to do. As you elevated earlier, only 5% of physicians are Black, and our population overall is 13% African American. And so at Eskenazi Health, we're happy to have 12% of our physicians that are Black compared to that 5%. We're very diligent with our nurses. 20% of our nursing workforce is Black compared to 6% nationally. Our overall workforce is 43% diverse, 29% of it being Black at all levels. Lisa elevated earlier that 29% of our senior leadership team is diverse, 18% of those being Black, including me. That reports directly to the CEO. And so, now I'll tell you, we don't rest on that data because it's not just about having diversity, it's also making sure those individuals feel included and are free to share their thoughts. As Lisa talked about earlier with one of the individuals with our leadership development program, because we want to capture all that innovation. We want to make sure that everybody feels comfortable. And so we also, I think, Dennis talked about the IU School of Medicine. We also collaborate with the IU School of Medicine and then 40 other academic institutions to make sure we're bringing in the best and the brightest to take care of our community that we're so privileged to serve. And so diversity is very, very important to us.
Absolutely. Okay. So when you talked about, actually, Dennis talked about the different disease states, particularly in primary care, it's important to have providers that look like the patients they treat. But it's not that a Black doctor has to treat a Black patient. Someone that understands the culture. And so it's not that it's all about race, but you have to understand the culture, you have to have some of the lived experiences, and you have to be able to relate. So I just wanted to make sure that that statement was made too. All right, Steve, hit us with something good.
Yeah, absolutely. You know, you put the pressure on me. You know, going back to Franciscan, respect for life is key. You know, we need to respect all of those patients that come through our doors. It's not a cookie cutter program that we have. Everyone comes through with different experiences, different needs. And we need to make sure that our staff truly understand what those needs are. And how do we do that? We have to do that through education. We have to help open people's eyes, think about those biases that we have. Some of them we don't even recognize that we have. And sometimes it's hard for those employees to really understand why it's important. Again, they're looking through it from their lens. They don't have the lens from our patients. And again, we don't shut our doors. Our doors are open to anyone, 24/7. You know, anyone comes through our door, we need to be able to respect them for who they are. And part of what we do from a human resource standpoint, we want to train and educate and help people be empathetic to those patients that are coming through to see us. So again, when you think about our core values, you know, respect for life, fidelity to mission, joyful service, Christian stewardship, those are the things that we want to walk every single day. And it's a journey. You know, we've all talked about, you know, we're not where we need to be. So it's a journey that we continue to educate our staff and help them understand what they need to do to take care of those patients.
And Doc, I'm going to ask you a little bit of a different question, but I think you're all over this. What is your hospital doing to recruit, retain, and promote minorities? And the reason why this is important is a lot of times qualified individuals are within your hospital system, but if you don't actively seek them out, then they don't get to where they need to be. And sometimes the criteria we're using to promote is a little bit unfair. For example, if you've been in a role for 15 years and you've done an excellent job, but you may not have the letters behind your name, what do we do with those people? How do we make sure that we're equitable in how we promote people from within?
I think that's a great question. So we'll start with recruiting and sourcing talent. So we are becoming increasingly more intentional about having talent pipeline strategies, going all the way back to high school, making sure that we are exposing children in our communities to healthcare and the benefits of healthcare, and starting with providing paid opportunities through internships, co-ops, et cetera. In addition to that, also partnering with the local institutions, Ivy Tech, IU Health, to ensure we're creating pipelines of diverse talent to come into IU Health. Once they're at IU Health, we have a lot of strategies that were in place, one of which is making sure that we are upskilling and cross-training those who've come in at entry levels, providing them with opportunities for upward advancement and mobility, and thereby increasing their wages as well. As it relates to the HR practices, and I think one of the ways to eradicate bias in the system is to make sure that DE&I isn't something that sits off to the side, but it's integrated into all of our HR practices. And so the means by which we do that is through, one, understanding those biases, those unconscious biases, and how it interfaces with performance management, succession planning, and ensuring that those practices are also as objective as possible. And so the more objective they are, the less chance there is for bias. And so we are really trying to strengthen a lot of our practices to improve upon that. From a succession planning perspective right now, one of the things that we realize is we'd like to strengthen our pipeline, particularly in our leadership levels, and there's just not enough people of color, specifically African Americans, that makes me comfortable. So we're being really intentional, for example, this year with asking every leader to look within their organization and identify 5 to 6 emerging African American talent, people who should be on our radars. And we're going to take that population and be very targeted and intentional about giving them visibility, giving them access to opportunities, and creating opportunities for them to further their careers through development and those types of things. But we'll do that year after year, and it's being intentional. And the more that we do that, the wider that group of individuals becomes, and the more visible those African American team members become, so that they can have opportunities as well. And so to your point about not having degrees, that's why we're doing a lot of that internal training. So we'll bring someone in as a housekeeper, but then give them an opportunity to be trained as a medical assistant. We'll bring them in as a food service worker, but give them an opportunity to be trained as an EMT. So sometimes people didn't have the privilege of going to an academic institution, but we want to provide them with all the education they need to be able to have healthy and vibrant careers.
Awesome. Save the best question for you. So we'll take some, I'm ahead of schedule, right? Yeah. So we're going to take some audience questions, but before, let me just make a comment. So when we think about healthcare disparities at the zip code level, we're often talking about women and children. And so I want to make the connection between, yes, we're supporting African Americans, yes, we're supporting those that have been underrepresented, but let us not forget women make up that group. And so when I see women leaders up here, it says to me that you guys are doing a phenomenal job. To have women in leadership roles who will continue to have more women in leadership roles is extremely important. So thank you. All right, couple questions. If you have questions, send them to the left. I guess this left. All right. Okay, let me see if I can read this. So, I know community in Eskenazi brings peers in for behavioral health, like NAMI. What about Franciscan and IU Health?
Can you read that question again, please?
I know community in Eskenazi brings peers in for behavioral health. What about Franciscan and IU Health? Are you bringing in peers for behavioral health programs? I'm assuming, is that how this question?
Right. And that word is none.
None.
That's the last one.
I'm not sure for Franciscan Health. Lori, are you aware?
Dennis, you want to come?
I'll save Adrian. For IU Health, we do have peer coaches, because I think we've talked about the workforce issues, and one of them is that there aren't enough mental health providers. And so what we found is actually having peer coaches is a really critical resource. So in every one of our 16 hospitals, you can get a peer recovery coach and a peer behavioral health coach via telemedicine anywhere in the state that we are today. And that's the first interaction that we try and have, so that people in an emergent situation not only have a physician or a nurse to talk to, but actually have a peer coach as well. And I think we're going to have to train more peer coaches in lots of behavioral health settings, just because we can't solve the problem with psychiatrists. We can't, I think to Dr. Harris's point, we can't create enough psychiatrists to deal with the size of the problem.
Man, we got some great questions here. Let me just reiterate that when we're done with this town hall forum on the stage, the community health resource officers as well as the CEOs will be in the back and can take some questions as well. So I scanned through the questions, and I think this one is pretty important. So let's ask this, and I alluded to this earlier. It says, I appreciated the questions and answers on intentionality regarding supporting HBCUs. But Indiana has its own predominantly black college right here in the backyard, which we happen to be standing in. How can Martin University play a role in any of these strategies?
Talk a little bit. We have a great relationship with Martin University. Martin had, in August of 2021, we collaborated with Martin to sponsor a program called Martin Works. And it's an apprenticeship program where we take students, high-achieving students from Martin, we put them in their respective field of study at Eskenazi Health, and we give them wraparound services and prepare them for full-time employment. And I am so excited to share that the majority of the students that we have engaged with Martin University are full-time employees at Eskenazi Health. So that is a resource that we have definitely tapped into.
Awesome, awesome. So I'm going to read this last question. There's two actually on here, and then I'll make a few comments. So how will any of the efforts today and successes transfer to the American Medical Association? Any ideas? How will any efforts here and successes transfer to the American Medical Association? And are the medical schools starting programs that are dedicated to learning about cultural issues? I think the second one is probably easier addressed.
So I think as the person in the academic institution, maybe twofold. One is there is an association called the American Association of Medical Colleges, which has all of the deans of all 140 medical schools in the country, as well as my peers, so 140 people who run those health systems. And this is a core issue that we talk about every time we meet. I think it is one that, again, as Dr. Harris said, the pipeline has to get bigger, and we have to see students of color succeed. There's actually, when you look at the data, there are more people of color who do not finish medical school but start than white students, and I do believe it goes back to, do you see yourself in your classmates, and do you have that support network that's required? So I think on the pipeline programs, that's critical, but I also think this notion of sensitivity to other cultures broadly, that we're really good at teaching biology, we're really good at teaching anatomy, and I think the emphasis on social backgrounds, what I talked about earlier, trauma-informed care, are you actually asking people, who are you really? What have you experienced in your life, is becoming a more prominent and regular part of medical school curricula, and I think that's critical. Because if it doesn't start in medical school, it's almost too late by the time you get into practice.
To chime in and actually shout out the School of Medicine. I think, first of all the meaningful work happens within communities. And so I think that there's work, hopefully, like this playing out all across the country, and that translates up to the levels of the American Medical Association to help inform policy. But I want to shout out the IU School of Medicine for helping us with a partnership that we have with the Center for Leadership Development, which is another critical part of our pipeline. And this, I see lots of heads nodding. Everybody knows Dennis Bland and the work we've been doing now for 20 years. It was actually, I know it was 20 years because I've been in my role as CEO for 20 years. And when Dennis came to talk to me about the Center for Leadership Development 20 years ago, that was about the only thing I felt comfortable signing on with without asking anybody if this was something I should do. There was no question that the idea that he had about starting with kids in high school and really helping prepared individuals to be successful, all the way up. And so the way that the IU School of Medicine plays into it is that we have a Rawls Scholarship Program that is named for Dr. George Rawls, a very prominent African-American surgeon in our community, just a pillar of competence and grace, and has done so much he mentored so many individuals. So this program's named for him. And every year, we bring about anywhere from 40 to 60 students within the Center for Leadership Development into Eskenazi Health, and the individuals within the IU School of Medicine, Dr. Kane, Dr. Bronson Tucker. There's it's an all hands on deck effort to help individuals understand that a career in medicine and the health professions is not only possible for them, but here's what it's going to take to do it. And it really starts with what you've got to be prepared for to do in high school, and then college, and then getting into medical school. But the medical students help individuals know what they're going to need to do. Our surgeons, we talked about Clark Simons, helps run it. Some graduates of the program who work for us are part of this. And so I think those are the things that they're organic and they just grow. And I hope and I expect that these things are playing out all across the country. They certainly need to be.
Thank you. So with that, I'm going to do a wrap up, and let me just start by saying that, to discuss race, the data would say that if you're an African-American leader and the fact that you even talk about race, your blood pressure goes up by 10 points, okay? And so for people to think discussing race and racism is easy, it's not. It's uncomfortable, but it's necessary. For us to understand that racism is a public health crisis, you have to have uncomfortable conversations. So as you leave, I would encourage you to continue to do so. The second is thank you again to the Indianapolis Recorder and the Indianapolis NAACP for being trusted community-based organizations for us to have responsible conversations on race. There'll be an opportunity for questions in the back. Please approach the CEOs and their leadership with questions because there are way too many here for me to address in the time allotted. Thank you again, and I appreciate you. Remember that there's another town hall that will be in November. Visit the websites on both the Indianapolis Recorder and the NAACP to do so. Special thanks to Martin University. Special thanks to Martin University. And thank you all. Thank you.